Hey, this is Jessica Anderson, and I'm presenting my pharmacology case study on otitis media. The presenting complaint includes a 3-year-old male that comes to the emergency department at 2 a.m. with crying, fever, and pulling at his right ear. Mom states he just finished an antibiotic, and she thinks it was the pink medicine, about 3 weeks ago for an ear infection. Mom also tells the nursing staff that he has had several ear infections in the past and that he also has sensory processing disorder, and she feels that looking in his ear will be traumatic, and she basically wants the provider to prescribe the antibiotic so they can go home and he can start feeling better. Upon assessment, patient is febrile at 100.9. He is fussy but cooperative. He is rubbing both eyes, which appear very red and have yellow-green drainage, and he is pulling at his right ear. The patient's past medical history includes ear infections, sensory processing disorder, pneumonia, and RSV. Surgical history includes circumcision. All vaccines are up to date. He does live at home with mom, who is a smoker, and 4 other siblings. Current medications: he just finished the pink medicine 3 weeks ago for a ear infection. The patient weighs 14.5 kilos and 36 inches tall. So questions to consider is, what is the probable diagnosis? Are there labs or tests that need to be performed? How can the provider be sensitive to sensory processing disorder while doing a thorough examination? What medications, if any, should be prescribed? And what education or follow-up should the patient and mom receive? Let's address the sensory processing disorder to begin with. Mom requested that the provider not traumatize the patient by not looking in his ear, but it's very important as a provider that we can thoroughly assess the patient. And why do we need to do this? Well, one, the tympanic membrane may be ruptured. There could be a foreign body in the ear causing the discomfort that would need to be removed, or the ear could be completely normal, not needing any kind of antibiotics. Some of the things that we can do to help address the processing disorder is allowing the patient to sit in the mother's lap. Often this will allow the child to remain calm, and the provider can slowly and gently assess, making sure not to overstimulate the patient. Distraction is often key in pediatrics. Sometimes we offer child life services, things such as blowing bubbles or letting them play on the iPad are good distractions. And it only takes a moment to examine the ear and is important in fully treating the patient. Upon assessment, the patient allows for examination while sitting in mom's lap without any kind of distress. We notice that the provider finds that the right tympanic membrane is red and bulging. The patient has red conjunctiva bilaterally with yellow drainage noted from both eyes. He is flushed and warm to the touch, which is consistent with fever. So what could our diagnosis and treatment for this patient be? Diagnosis is right otitis media with bilateral conjunctivitis. Treatment: amoxicillin, clavulanate, or augmentin. So why should we choose augmentin over amoxicillin? Amoxicillin is usually the first line of antibiotic for acute otitis media, but as we discussed, our patient has had multiple ear infections, with the most recent 3 weeks ago, and he has failed with the amoxicillin treatment. He also has bilateral conjunctivitis. Augmentin is recommended for patients who have been prescribed amoxicillin in the last 30 days, for patients who have concurrent purulent conjunctivitis or has a history of reoccurrent AOMs that have been unresponsive to amoxicillin, and this comes from our textbook. So what is the mechanism of action of the augmentin? Augmentin contains both amoxicillin and clavulanate. Amoxicillin binds to penicillin binding proteins, and that's within the bacterial cell wall, and it inhibits bacterial cell wall synthesis. The clavulanic acid is a beta-lactam, and it's structurally related to penicillin that may inactivate certain beta-lactamase enzymes. So looking at the metabolism excretion of augmentin, the clavulanic acid is well absorbed orally. It's about 75%. The plasma protein binding is 22 to 30%, and it undergoes hepatic metabolism. Renal excretion accounts for greater than 50%, and plasma half-life is roughly 1 hour. Penicillins are generally well absorbed from the GI tract and bind to plasma proteins that are well distributed to most tissues and to the body fluids. Penicillins are excreted primarily in the urine. Good key to note is renal insufficiency prolongs the half-life and increases the risk of toxicity. So we want to make sure that our renal functions are intact before prescribing this antibiotic. A little more information on metabolism and excretion. Amoxicillin and clavulinate potassium are well absorbed orally. The pharmacokinetics of amoxicillin is not really affected either way by food or no food, but the clavulinate tends to be better when it is taken with food. About 25 to 40% of the clavulanic acid and more than half of amoxicillin are eliminated through urine without undergoing any metabolism. So what are some of the side effects of Augmentin? Nausea, vomiting, headache, diarrhea, gas, stomach pain, skin rash or itching, and white patches in the mouth or throat. Some contraindications, warnings, and drug-to-drug interactions include that amoxicillin clavulanic acid is contraindicated in persons having any kind of allergy to the penicillin groups, a prior history of cholestatic jaundice or liver dysfunction, and we should know that excretion of amoxicillin may be delayed as renal function is not well developed in neonates. So we need to be able to adjust those pediatric patients that are younger than 3 months. So what would we discharge our patient home with? Our diagnosis is going to be right otitis media with bilateral conjunctivitis. Our prescription is amoxicillin clavulinate potassium. We're going to do the suspension of 400 milligrams per 5 mLs. We're going to give 2.4 mLs by mouth every 8 hours over the next 10 days, and we would have no refills on this prescription. Our patient's weight is 14.5 kilos, so I got our dosing by saying that 40 milligrams per kilogram per day is our dose. That comes out to 580 milligrams a day. And if you divide that by 3, that's 193 mLs per dose, which comes up to the 2.4 mLs. And pedsquickcalc.com is a website, and it's also an app you can put on your phone that is really good to give you the dosages of antibiotics and other medications. And a lot of our providers use that app in our ED. As far as education goes, you need to educate the mom on the importance of the patient taking the entire medication as prescribed and following up with primary care within 5 to 7 days. Need to educate on the importance of not smoking around the child, and we also need to think about if we continue with these type of ear infections that a referral to ear, nose, throat may be something that needs to be discussed with primary care. And this concludes my case study. Thank you very much.